afternoon, good evening, and welcome everyone to today's Global Café. My name is Lucia Pannese, Director of Policy and Advocacy and Innovation at the International Federation on Aging. And today we have kind of a very interesting session exploring how games can support healthy aging and rehabilitation. So games, perhaps primarily seen as entertainment, have now been recognized for some of their therapeutic benefits, such as improving cognitive function, enhancing physical abilities, and providing emotional support. And so joining us today to discuss how games and technology can support aging is Ms. Lucia Pannese. Lucia is a passionate entrepreneur who established one of Europe's leading and pioneering serious games companies, which is a Milan-based company called Imaginary, in 2004. And with her background in mathematics and a creative multicultural mind, she acts as both CEO and research director and has published numerous international articles and papers. And her company Imaginary is recognized internationally for its innovative work playing a key role in European research. And the company has won and delivered over 30 European funded research projects and has received 15 awards for their work. So Imaginary's focus is on e-health and specifically on telerehabilitation, which we'll be speaking a little bit more about today, with one of their flagship products of Rehability, which offers physiotherapy and cognitive stimulation in the form of interactive games. So welcome, Lucia, and thank you so much for joining us today on the Global Café.
Thank you very much, Katerina, and thanks for having me.
Yeah, thank you so much for joining us. So we always kind of start a little bit at the beginning. And so I'm wondering if you can tell us a little bit about yourself and your story, and, particularly how did you become involved in the healthcare sector, being that, your background is in mathematics and more kind of that technology space.
Okay, yes. Let me start saying good morning, good afternoon, and good evening to everyone from my side as well. My name is Lucia Pannese. So as you nicely introduced me, I'm the CEO of a company called Imaginary based in Milano in Italy. My background is in mathematics. So that's what I did at university. And then after some years of working always in companies delivering digital technologies for, several different sectors, I decided to start my own company 20 years ago. And the focus was on serious gaming. So I guess we will get back to that in a moment. So games that have purposes different from entertainment. And what we did in the company was from the beginning to study how you can use those games, how you should design those games to serve serious purposes that should be well defined at the beginning. And we did that through a quite amazing series of research projects. So we worked on intensively on European research. And over time, we started 12 years ago working on a project about telerehabilitation. So we liked that. The topic was interesting. It could make an impact. And we decided to go on working in that. So that's how I landed into telerehabilitation.
Amazing. So I want to, ask if you can explain a little bit more about what telerehabilitation is and, how it's being used currently and how is it different from traditional rehabilitation as people would kind of conceptualize it.
Yes, of course. I think we have to start with the issue that globally NHS systems are facing. I think we all know that particularly chronic patients are really increasing in number, also because lifestyles in general are not that good, I could say. So, but the number of specialists is staying constant, if not decreasing a little bit. So this ratio is really unbalanced and it's getting worse and worse. That is creating an enormous stress in terms of costs in a very general understanding of the topic of costs. It's creating long waiting lists. It's creating therapies that come too late and are too short very often. So that means, in other terms, a very poor quality of life for many patients, but also sometimes even recurring issues, so new occurrences, new diseases, if you want to call it like that, because therapy is too late or not intense enough. Mm-hmm. This is the same situation if you take Europe, Asia, or the US. So over most of the, should I say, developed countries, the situation is the same. And what telerehabilitation is trying to do is to study and to offer digital components that try to optimize time of specialists so that the same number of specialists can take care with the same efficacy level and with the same level of care of a larger number of patients. So actually being asynchronous. And the reason I say that is because you clearly asked me what is being done today. Very often I hear people, but even like public administrations and important stakeholders talking about telerehabilitations in terms of teleconferencing. So what we're doing now would in other terms be one of us is the physiotherapist, say, or the occupational therapy, or the psychologist, whatever kind of therapist you want to imagine. And the other one is the patient. So there's just a video conferencing system in the middle. Although this is actually, well, comfortable for the patient because he or she has not to drive to the specialist center or not to be driven to the specialist center, which means a third person involved there. It's not solving the issue because the therapist is still dedicating the same amount of time to that single patient. So what we really need is something asynchronous, which means that still the rehabilitation process needs to stay in the hands of the specialist, because obviously we're talking about a very sensitive area here. The therapy has to be really fine-tuned to the needs of the patient. So this has to be possible with the digital solution. But the patient has to have the possibility of staying at home, provided he or she complies with what we call inclusion criteria. So in other terms, it's not that everybody can then benefit of this option, but the clinic has to really decide what type of patients can benefit of this option. I just gave a couple of easy examples to understand. If the patient has a too high risk of falls, then maybe he or she shouldn't benefit of doing therapy on his or her own. But then it's better that this type of patient still goes to the clinic, but then others can profit of this solution. Still, therapists will have more time to dedicate to those patients who really need it. Another good example is the occurrence of epilepsy episodes, because we're still talking about digital components. So you should really limit the risks for patients. But then again, the patient has a therapy calendar and they can train from home. And data are then monitored by specialists. So this is a little bit how it should work.
Mm-hmm. Yeah, thank you so much for that overview. And, you know, I want to ask if you've, just as kind of an add-on to pick up on one of the things you said, have you done any, research, or do you know of any research that actually kind of measures that reduction in burden on, health systems or on specialist time? And I'm wondering if you can talk about that a little bit more, because I think that is something, as you mentioned, that's something that many national health systems are facing, across the globe, really.
Yeah, of course.
Mm-hmm.
Well, we are involved in this type of research and solution since 12 years. So we have been working over a quite extended time on not only on research, how to create such a solution, but also on piloting and validation studies, of course. Also because if we're talking about telerehabilitation, those solutions need to be then certified as a medical device. It's a CE medical device if you talk about Europe, it's an FDA if you talk about the US, there's a different FDA in Canada and so on. So every, geographical area has a different, perspective, or let me call it simply bureaucracy procedure, but the logic is the same. Mm-hmm. So you need a lot of research and data collection and observations before you can say that this solution fits the need. Mm-hmm. And fitting the need means, first of all, that you don't lose any efficacy if compared to traditional therapy. So in other words, what you're offering through a digital solution needs to have at least the same level of quality of care than a traditional solution. So if I do my tele-rehab at home with whatever kind of system, then I really need to be sure that I have at least the same level of attention and efficacy and quality and so on same as if I go to the clinic to see my therapist or therapist team. So that's the first thing, and that has been studied extendedly, and we have done studies in many countries also, because you cannot only concentrate on your home country or just a country where you happen to have some contacts in, and that's very fine. Then what you have to ensure is adherence, because clearly it's different if I say a nurse or a therapy grabs you by the neck and brings you to the gym, and you have to do your exercises because they're checking on you and they're like pushing you and encouraging you and so motivating you. You're at home alone, or anyway, without the specialist. I mean, maybe there's a caregiver or someone else. But you can also avoid switching on the digital component if you're not motivated correctly. So that means really that through motivation of the patient, we need to ensure adherence. And that's also another type of research studies that we need and that have also been carried out. And actually motivation happens to be very high, provided the solution was built with certain characteristics that I'm sure we will then also tackle here. So then that means that the patient is happy to do that, happy to do the therapy in that way, and they see the point, they realize it's useful for them to do it. Mm-hmm. So that's the second type of research. And then there's a part of research that you're aiming at with your question, which is medical economics. So is there a sort of benefit for the NHS system? And the answer is clearly yes. There are not a lot of medical economic studies out in literature yet. There are some, for example, our latest study or the study in medical economics regarding our system. The last one was published this year by a neurologist in Bilbao, in the Basque countries in Spain. And this neurologist, they calculated a saving of 60% in the cost of telerehabilitation therapy for Parkinson patients. What I say always is, even if they have been a bit optimistic, there's still a lot of money and time saved, because that's proportional with that type of therapy.
Mm-hmm. Yeah. Well, I want to come to kind of how games fits into all of this. So can you talk a little bit about, firstly, what are serious games? Because I think that's something that I personally wasn't very familiar with that term, serious games. In addition to how they support rehabilitation. And I think, we can talk a little bit more as well about kind of the design of these games as well. But first, let's kind of start at the beginning, which is, firstly, what are they and how do they support rehabilitation?
Yeah, okay, thank you. So serious games, the name sounds a bit weird sometimes because people say, why should a game be serious? A game should be fun. But we agree on that. The point is that the purpose that you have playing that game is serious. So there are games for purposes other than entertainment. That's actually the definition that you have. So it's actually a game, or you have rather, let me say, a sort of range of solutions that range from simulation to a game, to a video game. I'm a bit careful using video game because everybody thinks at those fantastic billion-dollar productions, which are not possible here, clearly. But the point is that you should have fun. You know very well what your objective is. So the point is not misleading the user, like, let's play a game and then behind their screen we have some other objective. That's not the point. The point is really taking off some burden. So you might have games that simulate situations just to train soft skills, for example, behaviors and so on. In this case, with telerehabilitation, we have games that translate motor and cognitive stimulation. So exercises, physical exercises with cognitive components. So they're mixed into functional tasks, because if you think in real life, every time you do something, you maybe move, like you use your arm or your leg, or you do something like that, and you categorize, you choose an object just to pick it. So you're doing both at the same time. Your motor and cognitive components work in sync. So that's exactly what we then combine in games. And the graphics that is being shown to the user is then I could say, guiding the movements and offering the cognitive stimulation. Now here, the point is how to design those games, because I see also sometimes out there are games designed just to be nice, just to be fun. But I would say that's a little bit easy. The real way to produce these games is called in literature participatory design. And that means that you have to have a very, very clear idea and clear description of who your final user is. In this case, it's the patient. So what type of patients, in what conditions, with what disease, in what age range, in what type of use, alone or guided, and so on. And then you should really co-develop the gaming part with those kind of people, possibly in different countries, because what you want to avoid also is cultural biases. I've seen, for example, games built around television programs and stuff like that. But if you haven't been living in that country when that type of television program was on, you cannot refer to the game. This is just an example of cultural bias that I've been witnessing myself. And I thought, well, what if somebody was from another country or living abroad in that period or whatever? So these things you have to avoid. And because the game needs to be motivating. So patients have to be able to refer to the game. They want to play it. They see the point. They think it's fun. And the result that you get in tele-rehab is that actually what we have published also is that patients forget that they are tired and they forget they're in pain. We have been working very, very much in neurology with patients between 60 and 95. And the games that we have produced were produced with this kind of patients. They're really in pain. I mean, rehab for them is something very serious, very tiring. They have pain. It's really also often difficult to motivate them to do the exercise in a gym. So with these games, we have seen like concentration gets on the game. They want to see if they can do better than yesterday. They feel the fun and the burden is taking off a bit. And also the therapist reports that that they are really facilitated because patients are complaining less. So they want to finish the therapy because they want to see if the score is better than yesterday. And that's very good, I think.
Mm-hmm. Yeah, that's interesting. It's kind of some behavioral, some psychology techniques a little bit to kind of have ways to keep people coming back, right?
Exactly. You tackle something which is hugely important, and it is that the design of such games cannot be created only from the technical point of view. The point is that you need a multidisciplinary team to design those games, and the psychologist is one of the main figures that is like the psychologist is the link in a way between technicians and the clinicians.
Right. Yeah.
That's fundamental. Yeah.
Yeah, I can see how that's hugely important because there's no use in having a great tool if people don't use it, especially kind of coming back to that self-guided, you know, if it's self-guided and self-directed.
Exactly.
So I'm wondering if you can share a little bit more on some of the different programming that Rehability offers, and, you know, share a little bit about kind of what the goals of those programs are, because I know you have programs for quite a variety of different types of rehabs.
Yes. Yeah, as I mentioned, we started with neurology. So first we concentrated on that a lot. And we even certified Rehability Neuro as a medical device. So that means that for patients with a stroke, MS, multiple sclerosis, or Parkinson's or spinal cord injury, this system is already under the CE certification. That means in Europe, it's certified. For the US and the other countries. Unfortunately, I mean, the studies are there, but then from a bureaucratic procedural point of view, the paperwork has to be repeated. In the meantime, we are, when I say we, it's teams of clinicians, of course, it's not our company. So we have to work with specialists on a daily basis. So clinicians are experimenting long COVID, because in the meantime, we have that as well, which wasn't there before. Chronic fatigue, Pompe disease, and sarcopenia. Sarcopenia is something typical of older people. So these studies are going on. They're showing nice results, but still, again, you have to study with groups of patients, collect data, publish them, and so on. In the meantime, we're also, from a research point of view, studying other types of pathologies like cardiac pathologies and so on. So there again, you have to start checking the games and designing with patients and so on. So the process is actually quite long if you take it seriously from a scientific point of view. One other thing that we're doing, which is very interesting, is that we are trying also a different use for our rehabilitate neuro, because it was created with older people, 60 to 95, as I said. So we're experimenting a rather social use of the games, of the same games. So in care homes, daily centers, and so on. So the logics would then be not really rehabilitating something like a neurology pathology, but if you think of residents, for example, in a care home, often they're just sitting there. I mean, it depends, of course, on the quality of the service of the care home, but in general, they have not a lot of stimulating activities to keep them a bit active, softly, to make them cheer up a bit, to, well, involve them also sometimes. So what we're doing, for example, through we're closing just one research project right now. It's called VR2Care. You might have heard about it in a previous cafe. So there we had test beds, so really project partners who have, for example, access to care homes, or they organize the services, the social services there and so on, or territorial services, who experimented socialization dynamics with our games. And there, for example, we see that the caregivers are tremendously important, because of course you need this sort of link with these older people. I said it's important to motivate them and to create technology with them. But then again, you have to sort of take them a little bit by the hand and introduce the technology to them. Because clearly the point is not only producing a technology with them, but then also like taking this initial fear how should I say, sometimes they feel they're not good enough to be working with technology, although they are really interested in being included in this digital space, because maybe they have nephews, they have heard about it, and they feel like left behind. Mm-hmm. So if you have some clever caregivers introducing them to this technology, then you get amazing results. They suddenly cheer up. We had cases where they start talking more, like communicating more, communicating with other residents more, trying to involve other people in this, and so on. While if you have caregivers which are a little bit more reluctant, or like they don't know how to do it, maybe they're less experienced and so on, then results are not that brilliant, I have to say. So this is something very interesting and important as well.
Mm-hmm. So yeah, I have a number of kind of follow-up questions from some of the things that you mentioned. But, firstly on that point, have you developed, or do you know of anybody that's maybe in the process of developing, a bit of a guide for these healthcare providers or carers or things like that on how to kind of introduce that technology?
Honestly, I don't know of any guide that is already there, but we have actually submitted already a couple of small projects, one with partners from the VR2Care project as a sort of follow-up action, just to really capture these experiences that we have been working on and observing and so on, and to start setting up a sort of model or blueprint, I could call it, for training staff so that they're facilitated. Because clearly, I mean, now the younger ones sometimes have the chance of being introduced to technology while they study, to become a caregiver, an educator, or even a therapist in this type of context. But they're the lucky ones in a way, I would say. So we're trying to set up, yes, something to facilitate this process. Exactly.
Mm-hmm. Thank you so much. So I want to go to a question from Shmuel from the chat. So Shmuel is a weekly contributor at the Global Café, and he is asking, how can games support older adults from poor and low socioeconomic groups of the population? So I'm wondering if you have any advice on, targeting some of those more specific populations within kind of the larger, broader sphere of older people.
Well, yes, that's one of the objectives of the whole story, actually, because the point is that, for example, if you tackle rural areas, there's hardly any specialist clinic over there. So normally the clinics are in the heart of towns or actually around the bigger towns and so on. So if you don't happen to live there, just around the corner, you might not be able to get there or to be taken there because you have nobody taking you or because it's too far away, simply, or because it costs so much and so on. So the logics is that when we plan these services, and now with we, unfortunately, I mean, not only us, but also the clinics, as well as the territorial services, so the NHS organization, unfortunately, again, it depends very much how health or care are organized in the single countries and in the single areas, because, you know, we have all different models. In Italy, it's public. In the US, I believe it's rather insurance-based and so on. So, or for example, in Scandinavia, you have suddenly municipalities popping up and offering care services after you have been discharged from a clinic and so on. So it's the relevant stakeholders who have to set up services that cover the territory. And the point is exactly that one, that if you live very far away, provided that clinically you don't have any sort of huge risk or issue, then you're the one who benefits more. The point is always reimbursement policies and so on. That's also a little bit slow still. Honestly, we as producers have not a real strength to push that. So the point is really making people know about it and discussing this and making pressure and putting up also pilot projects also in rural areas and so on, so that the benefits can be reported correctly, so that we speed up those processes.
So maybe just a practical question on that is this kind of form of rehabilitation, you know, covered, you know, reimbursed through kind of, you know, health plans and things like that in the same way that, you know, a traditional rehabilitation might be?
In general, not yet. There are many discussions. I mean, Italy is the country I know best because I happen to live here. But again, for example, just to give you this example, the ministry in Italy has already issued all the papers and the regulations last year. But we have a regional system, which means that after the ministry writes all the sort of bureaucracy paperwork for the country, then every single region, and we have 22, 23, something like that, I can't even remember, each one of them has to take it up and put it into practice, which means today some regions have it already, some don't. A few have it, the others don't have it. So, but those that are starting are really like doing pioneer work, because they're putting the system into what I call the routine in the end. And they are also collecting data and demonstrating how well it fits the need and how much time they save and how much money they can save. So that is then speeding up the process, and you know, like the others cannot ignore that.
Yeah, absolutely. So, you know, to that point, I want to ask a little bit about if you can share kind of some of the feedback from people actually using the games, because I think that must also go a long way as well in terms of, you know, showing the value of this and showing that, you know, not only kind of the health outcomes, but also that people are willing to use it. And people kind of enjoy using it. It achieves kind of the goals that it's set out to. So I'm wondering if you can share some kind of examples or stories of how these games have kind of contributed to the well-being, the function of older people.
Yes, of course. I mean, in 12 years, we have collected plenty of stories. I can tell you a lot about it, but for example, a couple of examples come from, it's a university clinic in Torino. Torino is in the eastern part of Italy, and they work with multiple sclerosis. So this is a really bad disease. So in the first trial that they did, the patients received what we call a home kit, because sorry, what I didn't tell you is how a patient does the rehabilitation and how they play with games. So bear with me a minute just so that we're all on the same page. So you see the graphics on the screen with objects moving and so on. And the interaction is with your free body movements, so with arms, with legs, standing up from a chair, sitting down again, or mimicking a step, or like turning working with your balance, so moving the torso and so on, without wearing anything, so without holding anything. So exactly as you are now, if you had the game in front of you, you could play, regardless if you're standing or sitting in a wheelchair and so on, because the system admits that all. So that's what you do. So we had patients, for example, working with this system for some months in the area of Torino. And then because it was a clinical trial, they had a limited amount of months. I can't remember if it's 3 or 4. All the durations and frequencies and so on depend clearly on the pathology. And then within the pathology on the state of the patient, they didn't want to give the home kit back. They wanted to continue, but the clinical trial had to go on. So because a patient gets a sort of little piece of hardware to attach to the TV with a little camera, and then they see the games in their TV screen, provided they switch on just a button on this little box. And they wanted to keep on doing that because they liked it, but they had to give it back for the next round of patients. So that already tells you how much they liked it. We were told, we had a small event in Presence, a very nice one, 1.5 months ago, something like that. And there was one physiotherapist coming from that clinic. So she was telling us real stories of her patients. And she said that because, again, it was a clinical trial, so they have to do pre-post tests. That means that the same patient needs to go through validated tests, so tests that give a real medical value as an answer. So those things that you put in a patient's record. So it was a lady, 71 years old, with a stick. She did the test. They recorded all the data. Then she went home with her little box and she trained for, like, say, 3 months again. When she came back, the physiotherapist said, she was really nice and funny. She said she thought the lady had forgotten the stick, maybe in the bathroom or something, because she had, whatever her name, you don't have the stick now. Where did you leave it? And she was honestly proud, but also a bit offended about the question. And she said, you know what? I feel so much more secure in my movements that I don't use it anymore. I mean, we were amazed because honestly, you don't expect that, because that's even an improvement. Even that colleague I mentioned already in Bilbao, working with Parkinson patients. Parkinson patients are older in average than MS patients. She said they could observe swifter movements. So the movements went more fluid, which is also an improvement. I mean, we don't have data about improvements. That would be a bit too much. That might come. But the trick there, the point is that because the patients see the point in exercising with those games, because they like it, because they don't feel so much the burden of doing the therapy, they really do it.
Yeah.
If they don't do it, they get worse, or in the best case, they remain as they are. But if they really do train, then it even might get a little bit better.
Yeah, no, certainly. I mean, I think it makes sense that people want to do these games and then they want to continue. And I can imagine that it is a much more, fun, comforting experience than going into a clinic or things like that. So I can imagine that is a far better, far more enjoyable experience, right?
Yes. Imagine that some simply say they like it much more because they during the same day, they can do it when they want. So, for example, say they didn't sleep too well and in the morning they have a headache. They don't need to do it then. They can wait. Or say in the afternoon, the nephew comes and visits them. Then they want to stay with the guy. And then they can do the therapy in the morning.
Yeah.
So even only this kind of organizational things are already improving their quality of life.
Yeah, absolutely. So, and I can imagine too, going to a clinic is not always the most pleasurable, the most fun experience, right? Like,
definitely not. But also really they're in pain. And if you think about it, when you're in pain and you concentrate on that, you're really aware of that. We have seen videos of a very compromised patient in Germany some years ago, of course, from the back for privacy, whatever you want. But this person was not really able to stretch his arm. So we saw the video without the games, and the patient was really concentrating, like looking to his arm. He was a man, to his arm and trying desperately to stretch it, although they had provided him with something to leave or make it a bit lighter to support the arm and so on. But he was really concentrating and looking at the arm. And then they put a game in front of him, one of our games, and the patient was suddenly looking to the graphics because he wanted to understand what he had to do. And suddenly the movement was really better. But when you move, you don't look at your arm and so on. So your concentration is on what you want to do.
Yeah.
So it gets more natural also.
Yeah, no, it's really incredible, I think, how that switch, and again, we were talking about psychology, right? Like that kind of psychological switch can really make a huge difference in somebody's movement and physical abilities. So I want to ask, we talked a little bit about this idea of, having these games exist for, a little bit more social connection, a little bit more kind of entertainment purposes, maybe more of that mental health kind of function, maybe. Yeah, I know you're kind of not quite, but
mental health is a bit different, right?
Yes, but I do think it is an important connection because we know that, loneliness or, even some of that can be a huge contributor to a lot of different, health impacts. My point only to say it's a little bit more of that kind of, not for the physical kind of rehab, more for that kind of social.
You know what I did in Singapore some years ago? There was one part of the town, don't ask me which one because I've never been there myself. Anyway, they wanted to, they had some daily centers, but they knew they had a part of the older population, not, you said like loneliness and depression and so on, like really staying closed in their homes and not getting out, not socializing, which is very dangerous, and also not going to the daily center. So they figured out and they sort of like sent a mail, a real paper mail in their mailboxes to these people, inviting them to this free event where they even got something like coffee and a cake, something like that. And they invited them to play free games just to try something new and so on. So they could really get some of them out of their homes, go to the daily center, which is already the very first useful exercise for them. And then they organized a tournament with these games. So they put people in groups, so they had to socialize and talk about it, the tournament, and decide who is doing what game and so on, getting organized and then playing some games. And while the teams were waiting their turn to play, they were taking for free blood pressure and weight and so on. So they did a sort of screening of the population. So they were stratifying the risks that they had out there. So there's actually plenty of uses that you can imagine around these technologies as well, where the technology in the end is just an excuse.
Yeah, I think that's a really interesting kind of way at it, right? Is to, people want to play these games, people, maybe want to come out to a tournament or whatever it may be, and you're kind of tackling on these different health aspects to it as well. So I think that's a really interesting example of how this can be used.
Uplift the mood, like I saw quickly in the chat. That's correct. That's exactly the point.
Yeah. So I do want to go to a question in the chat from Cynthia. Cynthia, do you want to unmute and pose your question?
Yes, well, I started out by saying thank you. You and your company embody participatory design, and it is so refreshing, having been in gerontology my entire life, professional life. I'm wondering what lessons you could share about the importance of co-designing, and also have you changed or evolved in the way you have thought about designing for older persons, but with older persons, if that's changed for you, and I'll add something else, has it been a struggle at all with colleagues who might have a mindset that we'll design for them, you know, and then they'll come, as opposed to if we design it with them, it will be much more successful? Could you share your
Yeah, thank you very much. That's a super interesting question, actually. Well, I wish I had one of our lead psychologists beside me to answer the question, honestly, because it's them then leading these activities. Anyway, of course, I think it's fundamental to create it with them and not for them and then let them come. It makes a huge difference, because if you're not part of the target group, you're biased. It's never the same result. So there's no point in doing and experimenting. That's something completely different. No. I'm really talking about sitting at the same table, ideally in the same room with a coffee and a nice chat and stuff like that. And because you have to start from what is motivating you, the way you are, with your pathologies, with your fears, with your confidence towards technology, and so on. So this is fundamental, and there's no way around it, in our opinion. So that's the way we have always been doing it, and this will not change. Clearly, you have to have access to the patients, which is obviously not easy. So you cannot just be a software house and then knock at some door and say, hey, you know what, I would like to have 20 patients. Also because you have to know that you need 20, for example, and that they are representative enough, and so on. So we talked about rural areas, we talked about different countries. So even the people you work with have to be representative of all the types of users that are included in your target group. So that's why research has a huge role in this story, and that's why we exploited really several research projects from the very, very beginning 12 years ago to VR to Care right now until the end of June. We have just one further month to go, because then you have partners that are really paid to organize these groups, to find the people, to tell you how they are, to put you in contact with them, and so on. So this is fundamental. I'm not really sure if the type of activities has changed over time. Well, of course, the more your experience, the more feedback from previous work you take with you, that's clear. I don't really think it changed. For example, to create those games for older people, we started finding out what attitude they have towards technology. That's why I say that the caregivers and so on have to introduce them to the solution afterwards, but also what is motivating you in general. That's why I see a lot of games around out there, which honestly are not targeted to older people. I'm sure about that. The type of graphics, of course, I mean, our games, if you see them, they're not the fancy games produced by Pixar, but sorry, that's another objective, right? There's other budgets, but that's for other people, for other things. That's the difference also between serious games. And that's also one of the reasons why I don't want to call them video games. For example, full 3D is confusing for older people who start to have cognitive issues. It shouldn't be full 3D. It can be full 3D for children with no issues, just because they broke a leg skiing or doing some other things. But that's completely different, you know. The color schemes have importance, the size of the font, the space between the various elements. So there's really, really nothing that you have to take or you can take for granted. It's a real work of fine-tuning and recycling and changing. I mean, I always will remember one of our first stories was our lead psychologist, super happy of the very first prototype we produced, going to a clinic in Milano, fortunately. So he just took the underground with his PC under his arm, and he had to try with the first patients, just the very first rough structures of the game, just to see how it was. And the patient couldn't even get to the start button. We had tested it plenty of times in the office, But clearly none of us had a problem or like raising an arm or moving around to get to the start button. Of course, that's usability. That's clear to me. I mean, it's not that type of game, but still, I mean, it starts even there, you know. And one other thing that I would like, I hope then that I answered your question, but that is important and we didn't mention it. I see some solutions out there, technology-wise, they're cool. They're probably even well developed and well put together. But if you send your patient at home with a luggage full of technology, sorry, that's too complicated. They have an iPad in the, or a tablet in there. They have wearable sensors in there. They have a ball. They have some other things that, like, older people start losing the things at home. They forget to charge them. Maybe they disappear somewhere. It's too difficult. You have to keep it simple for them. So ideally, they shouldn't be doing anything. It is a little, I mean, something they have to do, maybe plug a piece of hardware in the TV and then switch on a button, something like that. You cannot think that you can offer more than that.
Yeah. Thank you so much. I mean, in very super interesting perspectives. And I think Cynthia's question is maybe prompting me to ask another question, which is, you know, I'm conscious that there are so many aspects that go into building this. You know, there's the healthcare professionals, there's the designers, the actual development of the game. We talked about psychology. So do you have any advice for that multidisciplinary work with your colleagues? Because I can imagine that if you get way too, you know, the graphic designer might be so focused on making the game look beautiful, but then as you're saying, that might not be what's best for the user, you know, or an older person that's actually practically doing the rehab. So do you have any advice for, you know, that multidisciplinary work, and how do you kind of keep the big picture in mind, you know, as you're kind of going through each step?
Yeah, that's a very interesting question. Again, the answer is not really straightforward because, in my opinion, first of all, you always have to have a scientific perspective, because these things are not something that you build just to make them nice or to make them fancy or whatever. I mean, these are therapeutic approaches. So you have to have a scientific approach to all the details, so from all the perspectives that build the whole story, the whole solution here. So even coordinating a multidisciplinary team is not easy. 20 years ago, when I started my company on purpose, I left a meeting where there was our technical director talking to the psychologist, because I realized they couldn't talk to each other. I just left on purpose. 5 minutes later, the psychologist came out running. Please, can you come back and translate? And I said, people, you have to learn to talk to each other, to listen to each other, to put yourselves into the shoes of the other one and understand what you're talking about. Yeah. Technology is not developed for developers. And this is the very first mistake that even very good developers do all the time. You mentioned also the therapist perspective. You know that I saw some systems with the same logics that our system have. So a doctor station, so that means a part of the system dedicated to the specialist, and a patient station, a part of the system dedicated to the user who finds only their games for that side of the therapy, fine-tuned for them and so on. And the specialist had really to work with vectors and angles and trajectories and so on to set up a personalized therapy plan. Now I happen to be a mathematician, but I don't want a physiotherapist to be either a mathematician or a physician or an engineer. They have another job, they have another mindset, they have another competence. So these things have to be hidden behind the lines, and we have to support and make their lives as easy as possible as well. So they have to have drag and drop menus to make it easy or a little bit quicker, or with more density of elements, with different types of elements or different color schemes and so on, but with drag and drop menus and super easy to handle things, or things that are super easy to handle, sorry. So you have so many perspectives to take into account. So I would really say it's not the job for a software house, never ever. So even if you're not the producers, but you have to choose a solution, if you don't have the eye of the expert telling you how that was created, ask some questions.
Mm-hmm.
Because if it's created only by a software house, it cannot work properly.
Yeah. Yeah, no, that's and great point and some really interesting lessons, I think, of, you know, because you really do need all these perspectives, but you also have to be able to talk to each other, you know, and everyone to kind of have their own expertise that they can bring to make the project best that it can be. So okay, we are kind of coming to the very end of our session. So I'll just ask one final question from Dr. Rao, which I'll just read it out just in the interest of time, which is, are you planning any games that can be conducted by individuals in their home with friends? So other, you know, if there's any kind of possibilities to have you know, multiplayer, I guess we could say.
Yeah, I'm not sure if the question means that the friends are together in the same room or multi-user or multiplayer like you're mentioning. So everyone is virtually present in the same virtual environment. Anyway, a couple of answers. In this VR to Care project that I mentioned already a couple of times, we have also multiplayer module that we added and we started working on. It's not very easy, and honestly, also literature is a little bit controversial because not all older people like it. They also don't like very often to be represented by an avatar, but then again, you have privacy issues, which also you have to take into account, because then you can look into the home of somebody else, and that's against every privacy regulation, for example. You also have to be present at the same time, and it might be a bit confusing. You need a better network. So there's a lot of issues. Clearly, if it's about entertainment, everything can be done, and also networking, connections, and so on will get better. Although, again, rural areas and so on, let's not forget that as well. So it's, well, it can be done. We're experimenting a little bit for this project. But if you're talking about therapy, so it really depends what purpose you have. Because if you're talking about physiotherapy, like in neurology, you never put two patients together.
Mm-hmm.
There's not two people who are the same, who have the same impairment, the same needs, the same speed, and so on. And it's extremely frustrating if you compare them.
Mm-hmm.
It's different if you say like the people in the same room, because that's also what we did in this project. We had, or the pilot partner in central Italy, they had some sessions with people together. So one was playing, the others were cheering, and then maybe they put together the results in a team, and they did some work, some social work around the games, and that works very nicely. Although the aim is not physiotherapy, the aim there is really social care and entertainment, stimulation, socialization, and so on, which is very important, of course.
Yeah, no, thank you so much for sharing that. So I am just going to take a couple minutes to introduce our speaker for our next Global Cafe and give you, Lucia, a few minutes to think about some key takeaway messages to leave us with at the end of the session. So thank you, Luana, for sharing that. So next week on the Global Cafe, I'm very pleased to welcome Mr. Jun Ryan Orbina, who is a technical officer of Demand and Behavioral Sciences at the Department of Immunization at WHO. And we will be speaking about social and behavioral interventions to improve vaccination uptake among older adults. So June is a very nice colleague of the IFA. So we really look forward to discussing that next week at our next Global Cafe. So hope to see you all there for that. So Lucia, I will come back to you to provide some final key takeaway messages from our session today.
Yes, maybe we can wrap up saying that never believe those people who say technology is not for older people. It has to be designed for them and specifically with them, which is much more important. And they have to be nicely introduced to it. So then they would love, and they're happy to be introduced in this new virtual space that they're often not acquainted with. So that's the very first thing. And then again, participatory design. So if you do have the idea of putting up a soft or digital solution for older people, or for any kind of target group, anyway, it doesn't really change if they're old or not, produce it with them. And for that, again, you need a multidisciplinary team.
Mm-hmm.
That's the only way to produce something which is meaningful, has impact, and meets the objectives.
Mm-hmm. Yeah, thank you. Thank you so much. I think it's a really fascinating innovation, and I hope to see it used more frequently, because as you mentioned, there's so many of these benefits on, you know, the individual and in their motivation to actually want to do these therapies, but also on the health system as a whole. So I'm not sure, you know, before we leave, I think your website, of course, your website has been in the chat, and I'm wondering if people can go on there and see maybe what the games are a little bit more about. So Luana has put it in there. So I really encourage kind of everyone to take a look a little bit more in depth into kind of how these games work, and explore it a little bit more. So thank you so much, Lucia, for joining us today and giving your time.
Thank you very much as well for having me and for being so full of questions and interesting stimuli for me.
Yes, thank you so much to everyone who joins our weekly Global Cafe, and of course asks questions and stimulates the fascinating discussion, as well as thank you so much to the IFA team that helps to put this on every week. So wishing you all a great weekend, and we'll see you at the next one.